Okay, so good evening, everybody. I welcome all of you for this another episode of Virtual Bariatric University. Myself and Professor Phoebe, we are the course co-directors for this virtual episode, and we have a stellar group of faculty today. So let me start by introducing our faculty. First of all, we have Sylvia Weiner from Germany. Sylvia is a great friend, and I've been associated with her and her great father, Professor Rudolf Weiner, since a very long time now. Sylvia is a very dynamic female surgeon, female bariatric surgeon, who specialized in visceral surgery and became the head of the bariatric surgery in one of the very famous German bariatric center, CAADIP. In 2019, Sylvia became the head of the department for obesity and metabolic surgery, and is currently leading the team of 30, including a big multidisciplinary team. Sylvia is also recognized on international stage for many presentations she has given. And now, as all of us know, she is the president, the new president of the Great Frankfurter Meeting. And I had the honor of participating in these meetings with Professor Phoebe and live operating in most of the meetings in Germany, and now this time from India at this meeting. Next, we have Dr. Marina Kurian from US. Marina is from New York, and she is the director of the New York Minimally Invasive Weight Loss Surgery Center. Marina has dedicated her professional life treating obesity with the lesser invasive procedures as possible. For that, she is nationally recognized as a leader in bariatric metabolic surgery. And Dr. Kurian has given a lot of media presentations on the Today Show, the CBS Evening, the ABC News Radio, Maxim, and the CBS Internet Radio. Marina has also authored many articles and book chapters on laparoscopic surgery. She's a co-author of Weight Loss Surgery for Dummies, a comprehensive and a very well-reviewed guide to weight loss procedures. So, Kurina, welcome to this show, and I hope we all learn more from your experience. Next, we have Padma Shri Professor Pradeep Chaubey, a teacher to most of us in India, somebody who has taught almost all the surgeons in bariatric surgery. We have been following his footsteps. Dr. Chaubey is the chairman of Max Institute of Minimal Access Metabolic and Bariatric Surgery at Max Saket in New Delhi. He established the Minimal Access Surgery Department at Sir Gangaram Hospital in New Delhi in 1996. Which was first of its kind in Asian subcontinent. Dr. Chaubey is the founding president of Asia Pacific Hernia Society, established in 2004, and he served as the president of this august organization from 2004 until 2009, and various other societies like Asia Pacific Metabolic and Bariatric Surgery from 2010 until 12, the Asia Pacific chapter of Obesity and Metabolic Surgery Society, the president of OSCE, the president of IAGS, and also the biggest honor for this country, he was the only president we had from India in the IFSO in 2012 and 13. And we did this meeting in New Delhi, and we are, as proud Indians, because of Professor Chaubey, we were able to host the IFSO at New Delhi at Taj. He has been felicitated with several honorary membership by prestigious international societies. And the names are endless, from Indonesian to Gulf to Egyptian to Japanese to American. And I think Professor Chaube has, you know, uh, set an example for most of the next generation surgeons like me, and we look forward to him, we look up to him, and that's the path everybody wants to follow. He's the editor of several textbooks, several articles, and I'm so honored to have a teacher, a great mentor, and a great human being on this show. Welcome, Professor Chaube. uh, Next we have Dr. Taskin from Turkey. Erin is a great friend. He is a assistant professor in surgery from Istanbul, and is famous for his Young IFSO initiative. He's a member of the IFSO EC chapter development in communication committee and the secretary treasurer of the Turkish Obesity Surgical Society. Uh, Dr. Erin Taskin trained under Dr. Bruno, and he did his fellowship in Bruges. Uh, his experience in invasive gastrointestinal endoscopy and endoscopic treatment for morbid obesity, has organized several international meetings. And one of those meetings, the Mediterranean Congress of Treatment of Obesity, is very famous. I attended that. And also, he was one of the hosts for the IFSO 2013 in Istanbul. And I was there with Professor Kobi to attend this great meeting and enjoy their hospitality. So welcome, Dr. Taskin, and I hope we get a lot of inputs from you for this procedure, which we are going to discuss today. Ashraf Haddad, another friend and a great colleague, a very valued colleague. He completed his minimally invasive advanced GI fellowship from UCSF, Fresno, and trained with one of the finest surgeons, Dr. Kelvin Higa, one of the most you can say prolific surgeons in US to train Ashraf. Ashraf spent some of his time with his mentor, and he developed his passion and attained skills in complex revisional bariatric procedures. 2015, he moved back to Amman to join his colleagues at the Jordan Hospital, and because he wanted to deliver the highest standards of care to his patients at his own place. He is a member of American Board of Surgery, American College of Surgeons, SAGES, and American Metabolic and Bariatric Surgery Society. Ashraf, welcome. It's an honor to have you, and we look forward to listen to you. Last but not the least, Dr. Sumit Shah. Dr. Shah is again a good friend, and he is a laparoscopic general and bariatric surgeon at Saket, Delhi, and has also been practicing at Max Super Speciality Hospital in Saket, Delhi, and SCI International Hospital in Greater Kailash. Dr. Shah is very active on the discussions in Aussie, and he is very technical, very scientific, and has a great knowledge, and has published several articles on bariatric surgery. At present, he is an EC member in Aussie and also in APHS, and he is an accredited reviewer of the scientific submissions related to laparoscopic and GI surgery in the Indian Journal of Surgery. So welcome, Dr. Shah. Now, once I've introduced the faculty, I think it's time for me to invite our teacher, our mentor, Professor Chaube, along with Marina and Dr. Ashraf, to moderate the lecture sessions. Dr. Chaube, please. Thank you.
Thank you very much. Good evening, everybody. And thank you so much, Mohit. I think you are really, we are so proud of you. The country is proud of you, and all of us are very, very proud of you, the way you have worked and you have created a niche in this area. And we feel very happy that we have a very, very long session. Good evening to all my colleagues, and of course, good evening to Mal, who has been a very instrumental for bariatric surgery in the country, because he has been coming right for almost 2 decades when we started bariatric surgery in India, and he has been an integral part of the training and teaching and promoting bariatric surgery in this subcontinent, apart from the other part of the world. Um, uh, and good evening, all my young friends who are with me on this panel. And we will start the presentation. Alan, welcome. I still remember Alan Taskin, who was when I was president of IFSO, and we had a meeting in Istanbul, and this young man, with all his energy and the guidance from senior Taskin, was responsible for the grand success of that meeting. So, and Alan, he will be speaking about the very interesting alternative, surgical alternative, and probably appearing the horizon as the option, another option related with this. So we will see whether he suggests this as a primary surgery, or he would like this to be introduced as the reoperative surgery. Over to you, Alan. All the best and good evening.
Hello, everyone. Thank you very much, Dr. Chobi, for the nice words. It's a great pleasure for me to be presenting with all these pioneers of surgery. And I would like to thank Dr. Mohit Bandari and also Dr. Malfobi for inviting me for such a wonderful meeting to be able to present. This is a very good opportunity to be seeing all of you in these hard times also. And today I will present you a new operation, almost experimental, that is founded by Dr. Melissas actually. I welcome all of you for the meeting, all the participants. It will be a very nice meeting with live surgery, and I'm very also happy that Dr. Bandari will do a live demonstration of this operation. This is actually sleeve gastrectomy plus jejunal anastomosis, but it is not a jejunal bypass because it's usually misunderstood because of the name. It's a side-to-side jejunal anastomosis for the treatment of type 2 diabetes mellitus, and for which also can be used as a interventional procedure for weight recidivism after sleeve gastrectomy. This is my disclosures. I mostly do sleeves and mini bypasses, but also other endoscopic procedures and these promising operation. And lastly, Renoir gastric bypass after trained by Dr. Dilamans. And the port sites that we use for this procedure is almost same as a standard bypass. We use 3 12mm ports and also 2 5mm ports and a 12mm port for the scope, just above the umbilicus. It's only 1 or 2 centimeters above. It's low because we will be working on the lower side of the body for the anastomosis. And we use also the 12mm ports lower than the standard Roux-en-Y gastric bypass. So all the ports next to the umbilicus should be also lower, and we have to have a triangulation. And what we do, this operation is firstly defined as being only a single anastomosis side-to-side operation. And we don't touch the stomach in the patients with BMI lower than 30, because we don't want very high weight loss, or because we do this operation for low BMI patients to treat diabetes. But at the first time, it was the Dr. Melissas explained this operation as taking only 100 centimeters from the trifid ligament, bypassing as you see here, and then from the cecum 100 centimeters, he also bypassed, and he made a side-to-side anastomosis with a single firing of a 60mm stapler. But nowadays, we only take 150 centimeters from the cecum. We leave more space for absorption because the first cases, there has been hypoalbuminemia. And we do the anastomosis isoperistaltic. So we have to see where the proximal part and the distal part of the intestine and anastomose accordingly. So we use stirring and clipping to define that. And for the patients with BMI more than 30, because this operation is also being done for the bulky patients, for the morbid obese patients, as adding a hypoabsorptive procedure on top of a sleeve. So if the patient's BMI is bigger than 30, we do a First, a standard sleeve gastrectomy, 30-60-40 French. And then we add the side-to-side jejunal anastomosis, as I have explained, 150 centimeters from the cecum. We take 150 centimeters of intestine from the cecum, bypass it, and then we take from trikes ligament another 100 to 120. I use 120 these days. And then I anastomose it with a single firing of a white cartridge. And this operation is simple technically because you have only one anastomosis as an hypoabsorptive mechanism, and it's relatively safe, but it has some tips and tricks that I will explain with the video. Now I will show you a video, a patient that we have operated in Bruges with Dr. Dilemans, because I convinced Dr. Dilemans that this operation can be favorable in patients with low BMI, and the patient has also opted out for this operation. Firstly, she wanted to be operated by a transit partition in Turkey, but then she has changed her mind, and because after she get to know about the operation, she wanted to have it. And the patient was a 35-year-old female with the weight at that time 85.7 kilograms and height 165 centimeters with a BMI of 31. So she's not morbidly obese. And she had type 2 diabetes mellitus since 2012, and she was using a lot of medications. Levemir 3 times daily, Humalog 25 units daily, Victoza, metformin 850 milligram by daily. And she had right nephrectomy because of an ectopic pelvic kidney in 1995, so she has one kidney, and laparoscopic cholecystectomy in 2017 and 2 C-sections, so she has been operated before. And in her examinations, in her labs, she had an hemoglobin A1C of 6.6%, vitamin D deficiency, and there was no contraindication for bariatric surgery, for metabolic surgery, and her diabetes were not controlled despite insulin and oral antidiabetics. So this is the reason that we have operated this patient, and she had endocrinology clearance before the procedure. So this is the video. I will explain the whole procedure on this video that we've done with Dr. Dilemans. You see, because of her kidney operation, she had some bricks in the right upper quadrant tube, so we have to do a bridectomy. Then we went to the thorax ligament, and you see on the instrument we had a little slip that we calculated according to that. And we put a stitch onto the proximal part of the intestine, so we can do the anastomosis isoperistaltic, and we put a temporary clip just 1 centimeter below that. Then we calculated the intestinal segments, the whole intestinal segments, and then we went to the cecum, and you can see we are measuring exactly the amount with the strip. And then we have calculated 150 centimeters from the cecum and do the same thing. So we put a stitch to the proximal, and then, sorry, I think the video stopped. Okay, sorry for the video. Now, then we put now we calculated again, and then we put the 2 loops together. We put the 2 loops together coming from the proximal and distal part. Sorry for the video, I think because of the high quality, it's a little bit slow on streaming. It was not like that on test, but I don't know. I think it's not working very well, but I will try to show you by skipping the images. Hope it works. Then we put the two loops together on the right side of the patient, and then we make an opening from the sides that will put the clips. So the proximal part will go to the proximal part, and the distal part will go to the distal part. Okay, I will skip so you can see the, sorry about the video, it's not working very well. This was a 4K video actually, but then we make the anastomosis with a single load of white cartridge. Single white cartridge. We make a side-to-side anastomosis. So it will be a 60 millimeter. It will be a huge anastomosis because we know that some of the food will go through the anastomosis and some of the food will go on the sides. But we don't know how much percent the food will go from the anastomosis and from the sides. So this mechanism is good because then we think that we don't have malnutrition by leaving some space for the food to go through the sides and from the anastomosis to reach terminal ileum. And then we close the defect by 3-0 PDS. We close the defect. And this I think is a good mechanism because Dr. Neto is also doing this procedure by magnets. So he's creating the same mechanism by putting two magnets endoscopically. So this only takes 35 to 40 minutes operation if you don't do the sleeve. And it's, I think, feasible. But the only ordeal here is that we have to close the big meso gap. So we have created a big meso gap by doing a side-to-side jejunal anastomosis. We will divert the food, but we have to close, you see the meso gap here. We have to close this meso gap. So we found that it's feasible to close the meso gap starting from the side of the intestine and going to the root of the meso. We have done it before from the meso to the intestinal side, but this is more convenient because then you can hang up and do it with your single hand. You can hang up your stitch and do the anastomosis. Here Dr. Dilemmas used the VLAC, but it's not necessary. You can use an unabsorbable suture to close the big meso gap, but I think we have to close this meso gap because we have some cases of internal herniation that I will show you now, that we have to go back and cut through the anastomosis, release the anastomosis to fix that. So after that, we put, Dr. Dilemmas put a drain. Thank you. And now, when we followed up the patient, I followed her when I was there for 6 months, and she has lost only 11 kgs. So she didn't lose a lot of weight. There was no protein malnutrition and some degree of GI complaints, some bloating, and a little bit of pain at the first 2 weeks. And now she has stopped Homolog, Victoza, Levemir, and metformin, and her hemoglobin A1C after 6 months was 6.2. It was controlled despite of the medications, and she was not on a strict diabetic diet, so she was not dieting. She told me she was eating baklava, she was eating some desserts. It's not good, but she was even eating that. Now I will show you one case that we have to go back because of internal herniation, bowel obstruction in my faculty. Because we had 3 patients like that, we have to convert it to normal anatomy. This was a 62-year-old lady with a BMI of 32, and she had a hemoglobin A1C about 8.5, and when we operated her, she dropped to 4.9. Her hemoglobin A1C dropped to 4.9 after 6 months. But she developed gallstones, 2 centimeter gallstone, and she has to be operated 7 months after, 3 months after her first operation. And after that, we had to operate her because of bowel obstruction 7 months later. and her CT showed omental brits and internal herniation of the proximal jejunal loops. And what we have done to her was reversal of the jejunal anastomosis, jejunal anastomosis, and we did it with a single firing of a stapler. And after that, her sleeve was, we didn't touch the sleeve, so she had controlled diabetes afterwards, after her follow-up. Now I have followed her up for 24 months, and she's still, her diabetes is under control. So here you see the anastomosis. When you go in after the operation, you will see the anastomosis like that. So we hang up the anastomosis. We have to cut through the anastomosis because there was an internal herniation and we couldn't reach the site. So with a firing of a 3 stapler, 2 firings, we cut through the anastomosis, and we had enough space for passage. So we don't need to take the whole side of the intestine and re-anastomose. And then we reached the omental brits, and it was very complex because she had cholecystectomy like 3 months after her operation, and then she has this surgery. So this is the 3rd surgery after her operation. And we have to lift up the omentum and see all the brits, because there was a big, huge brit at the mesoroot. So we have to go there and take out all the loops which went in through it. So we were careful because it was fragile, edematic, and we don't want to damage any intestinal loops. So we take all the loops out. And at that time, we saw that big brit coming through there. And when we cut through that big brit, you will see in 2 seconds, we were able to release all the loops. So in that case, we didn't close the mesogap. I think because of the multiple surgeries also, there was brits developed, and all the loops, intestinal loops, went through that big mesogap and created this mess. So we have to cut through all these loops. You see the brit here, it's the big omental brit that sequestrated the whole thing inside. So when we cut through that, everything was released. And the patient, then we have to put all the intestinal loops in order. And the patient did very well, and she was discharged 4 days later. And as conclusion, we now recommend that you have to close that mesogap in order to not to have this kind of brits and internal herniation. But despite we cut through the anastomosis, so we get rid of the hyperabsorptive part of the operation, she didn't regain a lot of weight, and her metabolic state was stable. So this was the first publication by Dr. Melisas, and he compared sleeve gastrectomy with sleeve gastrectomy only group. And what he found that he had a 2 homogeneous group actually. So he put 2 groups, he put all the patients with the similar demographic features into this study, and their body mass index were higher in this group. These are not lean patients. So they had 46 and 45.6, and the control group also was similar. And the 9 patients were diabetic in both groups, sleeve gastrectomy and sleeve gastrectomy plus jejunal bypass group. And they had comorbidities, hypertension in 9 patients, dyslipidemia in 76 patients, 7 and 6 in the other group, and sleep apnea, 12 and 13 patients. So what he has seen that with Sleeve Plus, of course, it's very reasonable because he added a hypoabsorptive part to these patients. He has done this operation first in morbid obese patients, and he has seen that the excess weight loss was greater in the Sleeve Plus group. It's 59% and 50% in the other group. And mean body mass index in 12 months was 29.4. Say, though they lost, Sleeve Plus group lost rapidly their weight in 12 months. And mean excess weight loss was also greater in this Sleeve Plus jejunal bypass group. So he did a gastrograph and also study, followed through time, and he saw that it's only 11.8 minutes. So all the food went through the anastomosis and the terminal ileum in a rapid phase. So this explains the GLP-1 response in this operation. And when we look at the comorbidities, they're 100% resolved for hypertension and dyslipidemia, and for sleep apnea, 75% resolved in 6 months' time. But what he had is the same problem. He had internal hernia in 4 patients that he has to go back, reverse the operation, anti-isoperistaltic anastomosis and nausea in 1 patient, hypoalbuminemia in 5 patients, and cholelithiasis in 9 patients. And he has to go back in 10 patients and leave the sleeve gastrectomy alone. So this was not very successful when he didn't close the mesogaps. So when we look at the literature on low BMI patients, we've seen that recently IFSO position statement and the American Diabetic Association guidelines that the surgery can be recommended in case by case in patients who are type 2 diabetics and who have uncontrolled diabetes. We can use the surgery, but it has to be case by case. So we have to choose the patients cleverly and follow up the patients in long term. So this gives us a way to operate some of these patients, although these procedures are still experimental. So we did a pilot study with 6 patients with Dr. Melissa's and from my clinic, and who had a BMI of 28 to 32. So they were lean patients with type 2 diabetes. And here you see all the patients were on oral antidiabetics, on all the patients. Only one was on insulin. And he was the patient with 9 years of diabetes, the case 3. And when we look at the excess total body weight loss, we see that we didn't have a lot of body weight loss. So because these patients are lean, the operation that you have to do should not malnourish the patient, and they shouldn't have very, very, very high total body weight losses. And we see that we followed up the patients for 38 months, and we see that the total body weight loss is between 8.5 to 16.5%. And the patient who lost the most weight was the patient who was on insulin, but he had a diabetes remission partially, because I think because of the duration of her diabetes, it was not totally remission. So when we look at this publication, we see that there were 6 patients with BMI range 28 to 32, and pre-op hemoglobin A1C levels were 6.7 to 8.5. The patient I operated was also similar, and the mean total body weight, so it's not very big. And we see that both in hemoglobin A1C levels in 36 months, we see a good low results in 36. As a second stage revisional procedure after sleeve gastrectomy. So they regain weight, and we use this operation to give them a chance. And in 3 cases, we have to reverse to normal anatomy due to internal herniation, as I have explained. And 2 cases were treated conservatively due to hypoalbuminemia. And out of all these patients, 20 patients had type 2 diabetes. So when we look at the resolution, we see 70% of type 2 diabetes resolution in 36 months, and 6 patients were on insulin preoperatively. And on 4 patients, we have partial remission and reduced insulin dose. And 2 patients, we had a relapse of type 2 diabetes, almost in 30 months. So they have to go back and use oral antidiabetics, but not insulin. And we look at the comorbidities. Hypertension in dyslipidemic patients, they were resolved, and the sleep apnea was resolved in 66% of the patients. They are not very morbid obese. So when we look at the revisional cases, this is interesting because we only did one anastomosis. We didn't touch the sleeve in these patients. And when we look at them, we see that these patients who regained weight about 48 months later their initial operations. And when we look at the pre-op BMI of these patients who have regained weight, we see that the most obese patient had a 36. So they're not morbid obese, but they're class 2 obese patients. And these having a BMI of 32 to 36. So 2 of them were diabetic and 2 of them were not diabetic. So we did this operation also for weight loss. So we see that the total weight loss in 36 months follow-up is between 19% to 24%. So it is effective actually, and you only add only one anastomosis. And the C-peptide values of all the patients were about 1.45 millimole. And when we look at the literature, that's how this operation was reported, we see also Dr. Fried's publication. He has compared this operation in rats, not in humans, but he has compared it with standard gastric bypass. And he's seen that the results were actually similar with doing Roux-en-Y gastric bypass or doing side-to-side jejunal anastomosis. And but what he did was a different technique. He took 100 centimeter, bypassed 100 centimeter from triceps ligament and 250 centimeters from terminal ileum. And he made 15 patients side-to-side anastomosis. He called jejunal diversion. And the mean reduction in hemoglobin I1C was in 12 months was 2.3%. So it was effective. So he has looked at the GLP-1 values and plasma insulin and glucose values in both groups, in jejunal bypass, in patients who were not operated, and also in Roux-en-Y gastric bypass patients. And he has seen similar results. So both operations were effective, and jejunal bypass was as effective as Roux-en-Y gastric bypass in rats. And there was no serious complication, hypoalbuminemia, diarrhea, or malnutrition. But I think because he didn't have any hypoalbuminemia was because of his technique. So he has left more common channel. I call it common channel, but actually it shouldn't be called, I think, because it's side to side, but he had left more space for absorption. So what are the advantages of this technique other than the other gastric bypasses? So we don't need to re-sleeve or manipulate the previous sleeve surgery when we use it as a revisional procedure. And we don't need to access the upper abdomen. And this can be also good because in some patients who were operated 3 to 4 times, there can be a lot of bleeds and a lot of lesions, and no need for a liver retractor. So it's easy. You can even do it with 3 ports, and can easily be applied on, and it's one anastomosis. And reversal is easy. If you make a wide anastomosis at the first time, then you can cut through the anastomosis, and it's very easy, and the complication rate is low. So as conclusion, this operation is still experimental because we have few cases together with Dr. Melisas, Dr. Fried, maybe with Dr. Mohak Bandari after this one, maybe he already has some. And it can be used in low BMI patients and also in morbid obese patients as a complex procedure. It seems to be promising and safe if you do it in a good manner, in good technique, with closing the mesogaps. And it can be used as a complementary revisional procedures for failed sleeves. And internal herniation seems to be the main problem. And it can be prevented by closing the big mesogap and fixation of the anastomosis to the meso, because it's a very highly mobile anastomosis. But we need more studies to justify this role in the near future. Thank you very much for your attention.
Thank you very much, Alan, for this new procedure, which is, as you mentioned, is experimental procedures. Just I have some observation. One, I feel that the chances of internal herniations are very high. Yes. Do you agree on that?
Yeah, I agree, because we were not closing the mesogaps, but in the patients where we close the mesogaps, there is no internal herniation, but there is some gastrointestinal problems. The patients feel the anastomosis on their left side because it's very mobile, and they have some bloating, and after eating, they have a lot of bowel movements because we changed, the whole system.
So, see, generally, what many of us who are doing gastric bypass in high volume centers, we see that internal hernia still remains the one of the very important aspects in gastric bypass, and many people would criticize gastric bypass for internal herniation because that can happen anywhere in any part of the world where the surgeons may not be used to internal herniation, and it may be not diagnosed on time and can create a large chunk of bowel becoming gangrene. So that is one point. And I've seen that the internal hernia which you have seen, you find it difficult to orient yourself, right?
Yes.
And you had to, dismantle the anastomosis and then only. So do you think it will be a big challenge for a non-bariatric surgeon to handle those internal herniation?
Yeah, I think it would be, because if you have such a complex one that I showed you, I have already some difficulty on that too, because the patient lost weight. It was a sub-occlusion, not a total occlusion, hopefully, because I could follow up the patients before the operation for a week before operating her, because there was passage. But it was a lot of momentum going through, a lot of adhesions, and it was really hard to manipulate the bowel, a lot of edema. And I think it should be prevented, because we thought that we shouldn't close the mesogap because we can create a cavity close, as the old surgeon says, you create a cavity close and it will create a problem. But it was not the case. I think this big mesogap always should be closed. And if it happens, maybe the new junior surgeon should get some help, because sometimes it's really hard to manipulate it.
And Alan, what do you think about the blind loop syndrome? Because all of us who are a little senior in the field, we have come across a lot of our cases, maybe a few decades back, when we used to do iliotransverse anastomosis, especially for ileal strictures and tuberculosis, which used to be very common in the country. So we have done a lot of bypassing, and the blind loop used to give us a lot of problem in long term, and many times you have to go back in, and they were perpetually sick because of the infections in the blind loop. So what do you think? Do you think these cases will, because it's a very large blind loop, very large blind loop?
I think the nature of the anastomosis prevents it, because there is it's side to side. The food goes both from the main route and just from the anastomosis. So I think there is not a big blind loop, but some like half and half. I didn't calculate it, but the food goes both ways, so it can drain easily. But if there's an obstruction like the one I showed, I think there might be the problem. But with the nature of the big anastomosis, 60 millimeter, I don't think there will be any problem. But we will see. We will see in long term.
Okay, so I would feel that way because I think all our young colleagues are doing the gastric sleeve, and there are likely to be failures which we have seen. So would you prefer to convert it into jejuno-ileal bypass, or would you prefer it to be converted into gastric bypass?
I think it depends. Like if it's a wider sleeve, I would prefer to do maybe a one anastomosis gastric bypass in some cases. But if I think that the patient will have a lot of reflux, then I would choose this operation. If also there was a lot of braids and I could not like the pouch, I cannot free the pouch. then I think this is feasible, because you only do one anastomosis and the patient loses weight. But this also needs some attention, because they have to close the gap, fix the anastomosis, do it delicately, otherwise they will have these problems. But I would suggest it. But only maybe after some more results, they can do it as their routine procedure.
Thank you very much. May I request Dr. Kurian to for his comments and some questions?
Sure.
Thank
you very
you.
much, sir.
Thanks.
It's a pleasure.
Thank you. Thank you, Dr. Chowbey. And Aaron, that was just a spectacular, really, presentation. What I'm most embarrassed about is that I didn't really pay so much attention to this, to see that this operation was presented by Dr. Melisas in 2012. And I may have seen it in the journal, but I didn't give it a lot of thought. And mainly it's because as we look at our revisions now with the sleeve, and we had the loop duodenal switch, but that was sort of where my focus was. I was really evaluating that literature, but now the loop DS is much harder to do than what you're doing. So do you find two things? One is, do you offer loop duodenal switch to any of your patients? And two, tell me again your limbs and why you changed them from the original paper, the original data.
I think loop duodenal switch is a good idea, also to prevent the reflux, of course. But the thing is, we don't have experience. I usually do one anastomosis gastric bypass to my patients who fail sleeve gastrectomy. But I think it can be feasible to do the duodenal switch. But for the surgeons who are young, and it's a hard operation, and you have to have a so they might try this operation, but we changed the 120 centimeters from the trites and 150 centimeters from cecum because of hypoalbuminemia. And at the first time, Dr. Melisas was doing also 100 centimeters from trites. So we are leaving more space for more absorption just to prevent, because you have to calculate the whole intestinal loops in order to actually decide that. But if you don't do that, I suggest to leave more space for absorption. So that's why we changed it, just to prevent hyperabsorption in the future.
And I completely agree with you about closing the defect. In addition, I also use the V-lock when I can get it. Sometimes they don't have it, but I like the non-absorbable for that. And so that was a great technique, starting from the bowel down. I usually go from the base up, but it depends on your health, right? If you have good health, then anything is possible. The other question about that anastomosis, the one that was obstructed, with the internal hernia, you persisted laparoscopically. Do you think that sometimes when I find there's a huge mesenteric defect, that the bowel will actually loop through not just once, but maybe another half turn through? And you opted to stay laparoscopic and then also divide the bowel to get it all clear. But why didn't you open? Like, if you had opened, perhaps you would have seen that it was a 1.5 turn through, and it would have been, you wouldn't have had to do that bowel surgery in addition. Your thoughts?
All right, but this was a special lady, an anchor woman. So she was very delicate, and I told her that we will proceed laparoscopically. So because of that, I opted out for cutting through the anastomosis, because I don't want to have more problems, because she was on TV all the time. So this was a little bit social. But you are right, you can do it with a small incision, just dismantle the bowel and get the bricks out. If it was not a problematic patient like that, I would maybe try to do it with laparotomy. It will be more easier for me.
Thank you. Those are my questions. Thank you so much for your presentation.
Thank you very much.
Araf?
Mal. Over to you, Mal.
Move on to Araf now. Dr. Haddad?
Yes.
Comments?
Aaron, yes, Aaron, thank you for this presentation. So sort of what Dr. Kurian said, actually now, if so, we are putting together as the scientific committee a task force on alternative bariatric procedures. And unfortunately, going through the literature, we missed this procedure. So probably I'll add it to the list after this talk. I went back and looked at this, and I have a couple of questions. Number one, this has, first it was published in 2012. Probably they started doing it, Dr. Melissa, in 2010. More than 10 years. And probably there's less than 80 patients in the literature. This is not picking up. Why do you think?
Yeah, the main reason is we had to do this operation under institutional review board application because they cannot be routine done in tertiary hospitals because it's not a routine procedure and it's not paid by the government. So we have done this operation some for private patients and also with a board review application. But patients in Turkey there are 35,000 cases done last year and 80% were sleeps. So you cannot convince a patient to go through this, or they would opt out for transit bipartition because it has been done before in other hospitals. So maybe we can do it with other centers. If we do a multi-center study, it will evolve more. But after we do it with international multi-center study, I think more people will grasp this, like in transit bipartition. Because with Dr. Santoro, with transit bipartition, it was the same. Like there was less cases, only he was doing it. Then it evolved. But the problem is we don't do it routinely. Because if we do it routinely, if I was the founder, I'm like adapted to this operation, maybe I would do it more. But because of these restrictions, I couldn't do like the ones that I was doing, like the single anastomosis or the sleeps, because of also for the patient selection.
Okay, so how do you choose your patients? Do you offer it to everyone and see who you can convince, or do you have a selection criteria? I think part of the issue is that the data is all over the place. So you have people with normal BMI, people with BMI 43, 35, and the sample is small. So it's going to be very hard to extrapolate data to any sort of useful endpoints with it being diluted over such wide range of BMIs.
Mm-hmm. Actually, the problem is if I have a patient like who has a BMI of 42, 43, when I explain her or him, he would opt out for a sleep firstly, like primary procedure, because she or she would hear that it's like a simple procedure, sleep, and it's safe. I don't think it's safer than a bypass, but you know the patients understand like this. So I would offer this operation especially for diabetic patients with BMI lower than 35, because they don't have many options, and the government also don't pay for their operations, and they don't have options. So other than doing a Santara procedure, I will do this one to my patients. But the only problem is if something happens to the patient, you cannot explain to the authorities that you did this procedure because it's experimental. So my selection will be lean patients for this one, only single anastomosis.
Okay. So you talk about the under 35 group or 30 to 35, which we understand. But the group of 25 to 30, it's been shown that even a Scopinaro's biliopancreatic diversion may not control their type 2 diabetes. So and they have a poor response even to a DS. Offering it to these low BMI patients that are overweight, not even obese, knowing that we have some data and some studies showing that even the most powerful operation we know doesn't work. What do you tell them?
Yeah, I tell them, like for every operation, for all the bariatric surgical operations, I tell them this may fail. And especially for this operation, I tell them this is like a junior, like we have just started doing this operation, so it's experimental. It can cure your diabetes for 2 years, but after 2 to 3 years, it can come back. So after having this discussion with the patient and checking his or her C-peptide levels, his or her reserves, and the duration of diabetes, if he's not diabetic more than 7 to 8 years, then I would offer that. But I will let him or she know about it, because otherwise, like they can sue me, or I have a lot of problems with them, and this is human, and I explain for all the patients actually for metabolic surgery the same thing, but for this one I give them a research protocol and I get their signature and explain everything, so they know about it. Otherwise, I don't do the operation to them.
Okay, thank you.
Okay.
Final question. Do you think this
Thank
is
you
going to
very
be a mainstream procedure
Yeah.
in the future?
Maybe if it's adopted, because it's easy and it's feasible and it's cheap. If it works well, if it shows its justification, I think it can be. But we have to operate more, and we have to have some research groups maybe to do more operations worldwide, in order and publish more. Because I have some more cases now, about 50. Then I can put them together with the other people and publish maybe 100 cases first. Then I think it can be adapted after some maybe randomized studies comparing with other options. It might be adapted in 4 to 5 years. I see good future.
Thank you, Aaron.
You are welcome, sir.
Thank you very much. At this time, we'll move on to the live surgery, and now have the consultant present the patient. Dr. Shashank Trivedi is fellow. Go ahead, Dr. Trivedi.
Thank you, sir. Welcome to Mohak. Today we have a 42-year male whose BMI is 45.5. He is non-vegetarian by diet, no addictions. He has osteoarthritis, obstructive sleep apnea, and type 2 diabetes mellitus, for which he is taking insulin. His HbA1c is of 8.6. Albumin is good level of 4.0. And the USG showed grade 1 hepatomegaly. The viral markers are negative. Thank you.
Okay, so good evening, everybody. Good morning, good evening. At our center, we do intraoperative endoscopy, as I've already mentioned. Intraoperative endoscopy is done to avoid any patient discomfort which can happen in the OPD. And most of these endoscopies are done for the purpose that we should be able to assess if there is any lesion at the G junction, for example, Barrett's esophagus, presence of hiatus hernia, or any other abnormality. So you can see this is a Z line. It looks perfectly normal. Once I go inside, we will see the stomach. So these are the stomach rugosities which you can see. I don't see any gastritis. This is the pyloric area. So that's the pylorus. And now this is the duodenum. So I'm actually into the fourth part of the duodenum here. Now my intention is to just make sure that I do not have a duodenal ulcer. Now I'm here into the jejunum. I'm going to just pull this scope back. And while I pull the scope back, I keep on seeing if there is a duodenal ulcer or anything which, can preclude the procedure. At the same time, we retroflex and check for the hiatus. So nicely visualized here. We don't have a hiatus hernia or anything. Now at this stage, once we have done the endoscopy, I would deflate the stomach completely and try and remove as much of air and fluid as possible. So this intraoperative endoscopy we have been doing since a long time now, and our results, we have also presented this data at multiple other forums for surgeons to understand if that has any value. To us, we feel that this helps us in basically avoiding any discomfort to the patient pre-operatively. We have a blanket consent which we take that we can change the procedure intraoperatively. If we have a large hiatus, we can convert that into a gastric bypass. If we have a Barrett's, we can convert that into a gastric bypass. Now about the port position. So I have a very simplified way of doing the surgery. We basically work with 5 ports. One is the optical port just above the umbilicus. There are 2 12 mm ports on each side in the anterior axillary line. which are two 12 ports on the sides of the optical port. This is exactly in line. The one on the left is exactly in line with the optical port, but one on the right, which I will use to fire the staplers and do my suturing, is 2 finger breadths above the optical port. So that's a trick here, that I place this a little bit higher for my convenience. Two 5 port, both 2 finger breadths below the subclavicular area, the subclavicular angle, both on the right and on the left side. And
Sure.
Mal, it's Marina. Is this not a primary revisional procedure? This is a primary just
It's a primary.
jejunal ileal, no sleeve, or he's doing a sleeve as well?
Yeah. So
Yeah.
can you hear me now?
Yes.
Yeah, we can hear you now. Go ahead.
Okay. So this is the port position primarily which we use. Now about your question, Marina, we are doing it as a primary procedure. So I will first start with the sleeve gastrectomy here. So as you know that the patient is diabetic.
Okay, continue.
Okay, now can you hear me?
Yeah.
We had a little bit of glitch, but now I think they sorted it out. Can you see the endoscopic view now? So I have, Marina, this is a primary case, and we are trying to do this sleeve gastrectomy first because it's a primary case. And once we do the sleeve, we're gonna show our technique of GI bypass. I think Professor Taskin has very nicely demonstrated his technique. A couple of things in his technique which I like, couple of things which we do very differently, I will be demonstrating here. So this is a straightforward sleeve gastrectomy. There's nothing special here, but our technique may be a little different than what maybe Marina does or what maybe Erin does. So or Ashraf does. Everybody has a different technique too and different instrumentation. We do a pretty straightforward sleeve. In this particular case, there is nothing which is very pertinent about this particular sleeve, but the points which we need to remember, like in any other sleeve, leave as minimal fat tissue available towards the greater curvature of the stomach while we do the omental dissection as possible, because this specimen has to be removed, and the more amount of fat we leave, the more problems we have while we remove the specimen. So I usually go very snug to the greater curvature of the stomach.
For the moderators and invited faculty, feel free at any time to make any comments or just join in.
I'll say, Mohit, it's Marina. You take these shorts a lot faster than I do.
Yeah. It's like, that's why I say we see sleeve gastrectomies, and I've seen surgeons, different surgeons have different technique, and every time I see somebody else operate, I learn something new. So not necessarily something can be correct or wrong. Is the way we do it, is the way we gain confidence in doing things. And if we see something good and we adopt and modify our technique, it's for our betterment. So my sleeves have been pretty much straightforward. We never do those fancy suturings and omentopexies and things like that, and very simple way of even doing the hemostasis of the sleeve. And we have been very happy with our results, so we don't change the technique. Now this is the pylorus here. I'm going to stop at this stage. Uh, uh, this is the area where we start to dissect while we do these SADs. So I'm going to stop exactly here. just little bit of additions, which I always like to remove because I don't want my anesthetist struggle to put the bougie into the duodenum. So that's it. We're just going to do a little bit of dissection here because I can see that there are some additions between the posterior wall of the stomach and here peripancreatic fat, which we're going to remove. So this helps in, later on while we are bringing in the bougie, we don't need to keep on moving the stomach back and forth with the bougie. So I just remove these additions, and this sort of a dissection just take additional 15-20 seconds. So now once I'm here, I would like to have a little bit better view of the angle of his. So what basically we do is we start to dissect a little bit distal from the area of the short gastric. So just pull all this omentum down. This is a little heavier patient than what usually is good for a sleeve, but that's okay. It's as far as the anatomy is concerned, we are able to see. And what I usually do, I start from here rather than go back. Just hold this momentum for me. Okay, nice. No. Just hold this like that. Okay. So you can see that that's the area, and I don't dissect too much here. Once I see the crust there, I don't dissect because I feel if we disturb this fat here, we sort of create a hiatus if it's not there. I stop at that stage. Can you bring in the bougie, please? And now we'll do the sleeve. So I have the bougie coming in.
What is the size of the bougie, Dr. Bandari?
It's 38 French here. 38
okay.
French.
Good. Do you think that we have to use a wider bougie in these cases? Because I also use 36, 38, but like we
Actually, the size of the bougie is just a rough estimate. We can make a sleeve as per our own visual perception. I don't exactly go by the size of the bougie. It's just to give me a very rough sort of a. So, we always leave around 2.5 centimeters to say around 2.5 to 4. So this, is around 2.5 and another, and this area is always, left. So this maneuver is important because I don't want to go close here. That's the place where most of these problems will happen. I usually would not like to go very close to that area. First firing is always a green, and then followed by that we have a blue. Can you push? Back मतलब पूरा back नहीं. And the last one will help us probably in dividing this fundus, taking it away. So that's the way, we do a sleeve. And as I said, it's not, the bougie size is a very rough estimate. I don't believe that it creates anything. Can create a sleeve of size bougie equivalent to 38 French by using a size 32. And at the same size, you can create a size 32 by even using a bougie size, which is of a smaller size. So that's a very rough estimate as to what we can do. So that's the sleeve. We do hemostasis by using simple clips. So I'll be using some clips here. Although the blood pressure is quite high and we don't see bleeding here, that's fine. Putting some of the clips. मेरे को सुबोध सर दिखता नहीं है ऐसे, बिना देखे नहीं कर पाऊंगा, आप सामने आओगे दिखेगा ही नहीं मुझे कुछ भी। इधर इधर एक काम करना है, थोड़ा सा इधर, बेचारे उनकी भी तकलीफ है, दिखेगा ही नहीं बेचारे उनकी। Okay, so that's fine. Let's just put a clip here. That's okay. There's a little bit of fat at the area close to the fundus. So there we have some oozing, and that can be easily taken care of by just holding it there and putting 1 or 2 clips. Okay, one more, please. And sometimes I keep a gauze there, and then when I come back, I usually will not find anything. There is that oozing from the fat is there. Okay, so now one more here. So now we are at a stage where we can start the important step of this procedure for which all of us are here. And that's called the JI bypass. So, I have a very different way of doing it. We can't do a bypass like what Erin has done at his center. Erin bypassed a lot of it, and I don't feel that we can do that in India. What we do is, we very occasionally do this case in our algorithm. It will not find a place usually because we have several other procedures which we perform. But just to demonstrate, if we have to do it, we cannot take that sort of a common channel. We need a very large common channel in India because most of our patients are pure vegetarians. So what I will do here is do a absolutely different thing. Now, if you can see here, this is the area of the ligament of trites. So I'll just demonstrate. So that's the ligament. And if we can see this ligament here will have 2 landmarks. One is the ligament and one is the inferior mesenteric vein. But I can see the ligament very clearly. What I do is I count around 100 centimeters from here. So that's the marking of 10 centimeters on both my grasper. 10, 20, 30, 40, 50, 60, 70, 80, 90, 100. So that's the 100 centimeter mark. And I know that this particular area here is the distal area, which is in my hands. And that bowel loop is the proximal which I counted. So I take all the bowel loop towards my side. So you can see that I'm standing on the right side of the patient, and I take all this bowel loop towards my side. And this is the proximal and that's the distal. So what I do basically is I take a hitch here, just a suture from my side, and this bowel loop here, I will again keep my orientation. So the best way to do this is to orient. So you can see, just show the C loop. So this is my loop here. This is the proximal, and we came all the way here, and this is the distal. So this end is the distal end, and that's the proximal. Now what I do is I hitch it here, just for the sake of teaching case. Usually we would not need to do this, but just because when we were talking about as a teaching case, let's do it to simplify things for our younger colleagues, and for even all of us, we get confused. So let's do this, and I'll again do the counting maths for you, the lie of the bowel. So you can see that this is the proximal here, that's the DJ flexure we started, and this is the proximal, and on the proximal loop I'll just put a clip just for the purpose of my identification. So this is the distal, this pathways, and I'll start to count from here. So now what beauty it gives me, give me a grasp, please. What beauty this does is that I can virtually see the proximal and distal. So again, this was my ligament of Treitz here. You can see that's my ligament. I started to count the bowel 100 centimeters, came in all the way this side, and I hitched the 100 centimeter bowel here. This is the proximal. Now I start to count from here 200 centimeters. So this is 10, that's 20, 30, that's 40, 50, 60, 70, 80, 90, 100, 110, 120, 130, 140, 150, 160, 170, 180, 190, and 200. So that's 200. And again, what I do is that I know that this is the distal and that's the proximal. So this is the proximal and this is the distal. Now what I do principally is I take this loop. So the distal goes to the distal. So I take this loop here towards my hand, and the assistant has the distal and I have the proximal, and I sort of make a small enterotomy here. So my assistant is holding the distal and I am holding the proximal, and I make a very small enterotomy here. Okay, so that's my enterotomy, and I just dilate it with my harmonic. Now my assistant will hold that, and I'm going to take control of what I did. So you know that I put the clip and that's the part which I marked. So I'm just going to remove that particular clip. And I'm going to make a enterotomy here. Okay, give me a stapler.
Mohit, do we know what the common limb is going to be from where you are, from the ilium?
No, we at this point we don't know, but we'll count
So
it.
you might be leaving about 1 foot or 10 centimeters of common limb. That might be too short.
We'll count it.
Okay.
Polysop, please. So this area towards me is the area where the preferential pathway won't be there. Only some of the part is going to go onto that path. That's what we presume, and most part going to come from here and going to go distally. At least that's what we are presuming. We don't know if that works. So we secured this one of the ends here, and now we know that the corners are completely secured at the lower end, and now we can secure the corners at the top end. I can also take this as a continuous suture. When I do a gastrojejunostomy, I usually cut this suture sometimes, and but here I can go continuously and close this. That's it. So this is the closure, and now once we have closed, we'll close the defect and then we'll count the common channel. So this is the anastomosis. Again, that's the distal portion which we will count to calculate the common channel. Now about the closure of the internal hernia defect. So the first step is that we demonstrate the internal hernia, and that's, so we need to pull this thing out completely here, and now what you see here is a big defect. So that's the defect which we would need to close, and I'll keep this bowel here. So now you can see, you can easily appreciate this large defect which we were talking about, and that's the area where hernias can happen. So what I'm going to do, the trick is I'm going to ask one of my assistants to hold this, and once he's holding it here, like that, it exposes the defect in a much better way for me. So that's the defect, and I can now, arrange this bowel here, and now I'm seeing this defect very nicely. Everybody can see. Give me a non-absorbable suture. So I usually start from the base here of the mesentery, and so we just need to expose that area first before we take a stitch. So, the base is the most important area, and once this base is taken, and our aim would be to create some of these adhesions which are lifelong, so that we avoid this possibility of having any internal hernia even later on. So now what I can do is I can go towards the Kifilard end by taking and opposing these two part of the mesentery. So this is one, and I'm going to take a little bit of base here so that I give a good closure. you would realize how handy it is for us to just have this area held by the assistant. I usually do this most times when we do the gastric bypass, but there the internal hernia defect is not as big as this one. But here it's a little bigger because we are doing a loop anastomosis instead of an end rule loop anastomosis. So that's a little bit of difference in the anatomy, which creates a larger defect as compared to the Roux-en-Y configuration. And now we'll take 1 or 2 stitch from the bowel so that it does not get twist. It's like an anti-obstruction stitch here, very superficial. And we can end the suturing here. So that's it. That's the closure of the defect. And now I'm going to calculate the common channel. Okay, cut that. Yeah. Okay, so let me start now. So we can start from here, or we can go from the IC and come back. Either ways. So that's the anastomosis which we created, as you can see. And this is the distal which we're going to count now. So that's 10, 20, 30, 40, 50, 60, 70, 80, 90, 100, 110, 120, 130, 140, 150, 160, 170, 180, 190, 200, 210, 220, 230, 240, 250, 260, 270. Actually, it's a little stuck on that particular side. What we can do probably is go to the cecum and calculate the common channel. So I'm going to go on the left side of the patient. I'm going to count from the cecum. Can I have a head up? Sorry, head down, head low. Right. Just give me a little bit of head low. Thank you. So that's the area which was stuck, which I was not pulling just to avoid the damage to the bowel. Because sometimes if we pull that area too much, it can create problems. Can I have right side up, please? Okay, so that's the area of the cecum. And I'm going to just rearrange my bowel because this has to be reoriented now.
I think this is a very good demonstration of the difficulty of counting the small bowel in obese patients. There are many doctors who advocate routine counting of the bowel. And you can see here when you have a super obese patient or a patient who is obese, that's very difficult to be able to identify the landmarks. Mohit, I think we're right there at the cecum. I know you tried to demonstrate it, but if you can get the nearest small bowel there and count, then that'll be fine because we might do more damage trying to demonstrate it. Yeah.
No, I'm there, almost there. I'm just trying to.
Yeah, I know you want to show it. Yeah.
That's. I'm just trying to show them the IC junction. That's it.
Okay.
Dr. Phoebe and Mohit, if Mohit can talk or if you can hear me. So just a quick question. So we measured 100 from the ligament, then we measured some more to make the JJ, then we started measuring the common channel.
Yeah,
is that
absolutely. Yes.
So Mohit, how much did you bypass? I missed that part.
So I just bypassed 100 centimeters was the length where I took the proximal stitch, and the 200 centimeters distally. So I basically bypassed around 200 centimeters.
So, okay, 100 and 100. So the sort of the blind end thing is only 100 centimeter.
Yes, absolutely.
No.
No, the blind end is 200 centimeters.
200 centimeters.
Yeah.
Wow. Okay, so 100 from ligament, another 200, so 300.
Yeah, 300, absolutely.
Okay.
Dr. Mohit, what would you do if it's a very short bowel, like after you count? Would you redo the anastomosis or just?
No, actually, see, to be very honest with you, whenever we do a mini gastric bypass up till until 200 centimeters of bypass, we have never counted the entire length of the bowel. And this was a debate which, it's not happening for the first time, but we have faced this debate even before. So I think this is the area of the bowel. I will now start to count proximally from here. I'm not able to demonstrate that, but this is that area. So this is 10, 20, 30, 40, 50, 60, 70, 80, 90, 100, 110, 120, 130, 140, 150, 160, 170, 180, 190, 200, 210, 220, 230, 240. Okay, so we have a 240 centimeters of a common channel, which is a little less as far as we are concerned, but I think this patient being a diabetic, we'll manage with that. That's not a problem.
So Mohit, is there a minimum number of total alimentary length that you would like to have?
So usually we would have been happy with a common channel of around 300 centimeters, which we usually keep. But in this particular case, as it is 250 centimeters, we don't have so much of problem doing that. There was another 15-20 centimeters which I could not count because I never wanted to cause that damage. But yes, we have 250 centimeters of a common channel here. So I'm not much concerned about the fact that this is malabsorption. So what basically I did was, just for the purpose of my ease, because we know that there's a difficulty in counting and we don't do that much amount of bypass. That's my logical conclusion to that. We started to count from here. We counted around 100 centimeters. From here, took a stitch, and then we went for a 200 centimeters distal to that. And then we did the anastomosis like we saw Erin doing or others do. So that's why I did not count the common channel, but Dr. Phoebe wanted me to count that. So I did that. We could not pull around 220 to 30 centimeters of the bowel, which was very close to the cecum. But that's the anatomy now. So this is the anastomosis. That's the loop, and this is the internal hernia closure. It's gonna go this way, and this area which here will be the blind loop, the one which is bypassed here.
Great work, Mohit. Thank you.
Great, very nice. Thank you, Dr. Mohak.
Thank you. Okay, is Dr. Kurian still there? And Dr. Weiner never did join us. Okay, it's left to you. Erin, do you have any more questions? And Dr. Haddad, if you have any questions, we'll be glad to answer.
It's a good variation of the technique, and I like the stitching to the abdominal wall. Sometimes I do it with mini bypass, not to lose the loop. I think it's a good idea for the new starters. But my thing is, I would do count from cecum first, because, you know, I understand like it's more feasible. And I think in India, there's less protein intake. But for the patients, maybe to be on the more safer side, I will first count from the cecum, like to see if the bowel length is too short or too long. But it's a good idea, like it's more feasible. And it's a super obese patient, so I think, like Dr. Mohak said, it won't be a problem. I think it's good. 250 is a good number, I think.
Well, really, you're correct. To be able to standardize what the common limb is, you should start from the cecum and count. But as Mohit did here, it turns out that the distance from the cecum is about 250. And so the functional limb is going to be 100 plus 250. So we're looking at about 350 centimeters. So this patient should do well, because most of the SADIs and pyloric sparing procedures leave about 300 centimeters of loop. And now we're leaving about 350 centimeters. So we should not have any more malabsorption than you would have with the SADI. Yes. And there are two other points that Dr. Bandari did not make. As you saw, he did an intraoperative endoscopy. And many surgeons are worried about intraoperative endoscopy because they're worried about dilatation of the loop of bowel. As you can see, he uses CO2 with minimal insufflation. And by the time he got to the small bowel, there was no distension of the small bowel. So that makes intraoperative endoscopy a viable option for doctors who do endoscopy to be able to do the evaluation intraoperatively, saving the patient an extra procedure, extra anesthesia, and an extra cost. And if you consent the patient, like Dr. Bandari said, for all the procedures, and then you have the alternative which the patient can have at a time. Do we have any questions from the audience, Mohit, and from the panel? Any questions from the?
I'll just remove the specimen in the meantime.
Okay. Are there any questions from the audience or from Facebook or anything?
I just hope that Dr. Phoebe and Dr. Bandari, that as usual, you keep a good database and you share a good publication of this. Because if this is truly a good procedure, we need a solid evidence behind it.
Yeah, okay. At this time, we rarely do it. We just probably talked about it because Dr. Melissa and I talked about it. It made sense in patients who have not lost adequate weight with sleeve. And it makes sense in patients who have a sleeve and are not responding from the metabolic perspective. And so you're increasing the PYY and the GLT secretion by doing a side-to-side enterostomy. So from his work, he shows that. And then this is something to consider. Some of the doctors are doing it in Korea for low BMI patients, like Dr. Tuscan said, patients with BMI of 25 to 32 who are diabetic, and you don't want to do any weight loss surgery. The weight loss is minimal, and the diabetic effect is very good. So, Mohit, do you have any closing remarks?
No, I think there are two things which I wanted to mention. The first one was that the bypass length which we do at our center in most of these bypass procedures is the overall length of bypass is around less than 300 centimeters. So most times I do not calculate anything from the IC junction. Even in our mini gastric bypasses, we do not calculate. We have never done in the gastric bypasses. The only one area where we would calculate the entire length of the bowel is probably revisions, where we're going to revise either a mini gastric bypass or a one anastomosis or maybe a gastric bypass or maybe a SADI. So that's why I do not calculate from the IC, number one. Number two, I believe that most of these cases we would come out, but yes, one of these cases we can have gut length less than 200 centimeters, and that there can be a problem. That can happen even 1 to 2% cases. I agree that is a problem in this particular technique. Number two is I mark my limbs in a special way, as Erin also saw, just to avoid the confusions. Number three, when I closed my internal hernia defect, I rotated the entire bowel on the right side towards me and asked my assistant to hold the anti-obstruction stick, because that gives a very good exposure of the internal hernia defect. These are the only 3 points I wanted to make. Thank you.
Okay. All right. With that, I would like to thank all the people who attended the webinar, and I would like to thank the faculty members for taking the time to come. At this time, do we, Himanshu, do we have the promo for next week's webinar? Thank you all. Thank you. See you all next week. Bye-bye.